Disorders of the aorta. The aorta is the largest artery and is responsible for supplying oxygenated blood to essentially all vital organs in the body. The most common vascular problems that affect the aorta are aneurysm, aortoiliac occlusive disease, and aortic dissection. Although the underlying etiology, pathophysiology, and clinical manifestation of these three aortic problems are significantly different. Aortic aneurysm. Aortic aneurysm. Aneurysms are outpouching or dilation of the arterial wall and are common problems involving the aorta. Aneurysm of peripheral arteries also can occur but are far less common. Aneurysms occur in men more often than in women, and their incidence increase with age. Etiology and pathophysiology. Aortic aneurysm may involve the aortic arch, thoracic aorta, and abdominal aorta. Most aneurysms, however, are found in the abdominal aorta below the level of the renal arteries. Three-fourths of, three-fourths of the true aortic aneurysms occur in the abdominal aorta and one-fourth in the thoracic aorta. Popliteal artery aneurysms rank third in frequency. Patients may have an aneurysm in more than one location. The growth rate of aneurysm is unpredictable, but the larger the aneurysm, the greater the risk of rupture. The dilated aortic wall becomes lined with a thrombi that can embolize, leading to acute ischemic symptoms in distal branches. A variety of disorders are associated with the aortic aneurysm. However, the primary cause can be classified as degenerative, congenital, mechanical, inflammatory, or infectious. The most common etiology of aneurysm of the descending and abdominal aorta is atherosclerosis. Atherosclerotic plaques deposit beneath the intima. Plaque formation is thought to cause degenerative changes in the media. Media means middle layer of the arterial wall. Intima means innermost layer of the arterial wall, leading to loss of elasticity, weakening, and eventually aortic dilation. Male gender and smoking appear to be stronger risk factors of abdominal aortic aneurysm of aortic origin than hypertension and diabetes. Several studies have shown a strong genetic predisposition in development of abdominal aortic aneurysm. The familial tendency to develop aneurysm is related to a number of congenital abnormalities including specific defects in collagen. Less common cause of aneurysm formation include penetration or blunt trauma from motor vehicle accidents. Inflammatory aortic aneurysms, inflammatory aortitis, and infectious aortitis. Classifications of aortic aneurysm. Classification. Aneurysms generally are divided into two basic classifications, true and false aneurysm. A true aneurysm is one in which the wall of the artery forms the aneurysm with at least one vessel layer still intact. True aneurysm can be further subdivided into fusiform and saccular. A fusiform aneurysm is circumferential and relatively uniform in shape. A saccular aneurysm is a pouch-like with a narrow neck connecting the bulge to one side of the arterial wall. A false aneurysm or pseudoaneurysm is not an aneurysm but a disruption of all layers of the arterial wall resulting in bleeding that is contained by surrounding structures. False aneurysm may result from trauma or infection or occur after peripheral artery bypass graft surgery at the site of the graft to artery anastomosis. They may also result from arterial leaking after removal of cannula such as upper or lower extremity artery upper and lower extremity arterial catheter and aortic balloon pump devices. Clinical manifestations of aneurysm. Thoracic aorta aneurysms are often asymptomatic. When symptoms are present, the most common manifestation is deep, diffuse chest pain that may extend to interscapular area. Aneurysm located in the ascending aorta and the aortic arch can produce angina from disruption of blood flow to the coronary arteries and hoarseness as a result of pressure on the recurrent laryngeal nerve. Pressure on the esophagus can cause dysphagia. If the aneurysm presses on the superior vena cava, decreased venous return can result in distended neck veins and edema of the head and arms. Abdominal aortic aneurysms are often asymptomatic and frequently detected on routine physical examination or coincidentally when the patient is examined for an unrelated problems. Example: abdominal X-ray, ultrasound, CT scan, intravenous pyelograms, or abdominal surgery. On physical examination, pulsatile mass in the periumbilical area slightly to the left of the middle left of the midline may be detected. Bruise may be auscultated with a stethoscope placed over the aneurysm. Physical findings may be more difficult to detect in obese individuals. Symptoms of abdominal aortic aneurysm may mimic pain associated with abdominal or back disorders. Compression of nearby anatomic structures may cause some symptoms such as back pain from lumbar nerve compression or epigastric discomfort or altered bowel elimination from bowel compression. Occasionally, aneurysm spontaneously embolize plaque, causing blue toe syndrome. Complications. The most serious complications related to an untreated aneurysm is rupture. If rupture occurs posteriorly into retroperitoneal space, bleeding may be tamponaded by surrounding structure, preventing exsanguinations and death. In this case, the patient often has severe back pain and may or may not have back or flank ecchymosis, gray turnus sign. If rupture occurs anteriorly into the abdominal cavity, most patients do not survive long enough to get to the hospital. They die from massive hemorrhage. If the patient does reach the hospital, he or she is hypovolemic shock with tachycardia, hypotension, pale, clammy skin, decreased urine output, altered level of consciousness, and abdominal tenderness on palpation. Diagnostic studies, chest X-ray are useful in demonstrating the mediastinal shield holes and any abdominal widening of the thoracic aorta. A plain X-ray of the abdomen may show calcification within the wall of abdominal aortic aneurysm. An echocardiogram assists in the diagnosis of aortic valve insufficiency related to ascending aortic dilation. ECG. ECG may be performed to rule out evidence of myocardial infarction because some patients with thoracic aneurysms have symptoms suggestive of angina. Ultrasonography is useful in screening for aneurysm and to seriously monitor aneurysm size. A CT scan is most accurate test to determine the anterior to posterior length, the cross-sectional diameter, and the presence of thrombus in the aneurysm. MRI also may be used to diagnose and assess the location and severity of aneurysm. Angiography. Anatomic mapping of the aortic system by contrast imaging. is not a reliable method of determining aneurysm diameter or length. It may, however, be helpful in providing the physician with accurate information about the involvement of intestinal, renal, or distal vessels. It is also useful if a suprarenal or thrombo or thoraco-abdominal aneurysm is suspected. Collaborative care. The goal of the management is to prevent the aneurysm from rupturing. Therefore, early detection and prompt treatment are imperative. Once an aneurysm is suspected, studies are performed to determine its exact size and location. A careful review of all body systems is necessary to identify any coexisting disorders, especially of the lungs, heart, or kidney, because they may influence the patient's surgical risk. If carotid or coronary artery obstructions are present, they may need to be corrected before the aneurysm is repaired. For individuals with a small aneurysm less than 4 cm, conservative therapy typically is initiated, which consists of risk factors modifications, decreasing blood pressure, and monitoring aneurysm size every 6 months using ultrasound, MRI, or CT scan. Based upon the best available evidence, 5.5 cm is the threshold for repair in the typical patient. However, interventions at a diameter less than 5.5 cm is indicated in women with abdominal aortic aneurysms. Surgical intervention may occur earlier in younger, lower risk patients or if the aneurysm is expanding rapidly. Surgical therapy. Preoperatively, the patient is hydrated and any electrolytes, coagulation, and hematocrits abnormalities are corrected. However, if the aneurysm has ruptured, emergency surgical interventions is required. The surgical techniques involve incising the diseased segment of the aorta, removing intraluminal thrombus or plaque, inserting a synthetic graft, Darcon or polytetrafluoroethylene (PTFE), which is sutured to the normal aorta, proximal and distal to the aneurysm, and suturing the native aortic wall around the graft so that it will act as a protective cover. If the iliac artery also are aneurysmal, the entire diseased segment is replaced with a bifurcation graft with a sacral aneurysm. It may be possible to excise only the bulbous lesion, repairing the artery by primary closure or by application of an autogenous or synthetic patch graft over the arterial defect. Use of transfusion, which recycle the patient's own blood, has markedly reduced the need for blood transfusion during surgery. All abdominal aortic aneurysm resection require cross-clamping of the aorta proximal and distal to the aneurysm. Most resection can be completed in 30 to 45 minutes, after which time the clamps are removed and the blood flow to the lower extremity is restored. If the abdominal aortic aneurysm extended above the renal artery, or if the cross clamp must be applied above the clamp, removal should be ascertained before the closure of the abdominal incision. The risk of postoperatively renal complications such as renal failure is increased significantly in the patient who has surgical repair of AAAS above the renal arteries. Endovascular graft procedure. Minimally invasive endovascular graft is an alternative to conventional surgical repair of abdominal aortic aneurysm. The endovascular technique involved the placement of a sutureless aortic graft into the abdominal aorta inside the aneurysm via a femoral artery cut down. The graft is constructed from a Dacron cylinder, and the surface of the graft is supported with multiple rings of extra flexible wire. After the compactly folded graft is delivered through the shield to the predetermined point, the graft is deployed, pressed, implanted against the vessel wall by balloon inflation, and anchored to the vessel by a series of small hooks. The blood then flows through the endovascular graft, thus preventing the further expansion of the aneurysm due to pressure. The aneurysmal wall will be to shrink over time because the blood is now being diverted through the endograft. Patient must be strict eligibility criteria to be candidate for the use of endovascular devices. Endovascular repair is the most advantageous for all the higher risk patients. Patients with aortoiliac occlusive disease or renal artery involvement are not suitable candidates due to anatomic differences. Endovascular repair may not be an option for many women. Some of the devices are custom made for each patient using data for CT scan. Using data from CT scan, angiography, and ultrasound. In other institutions, the physician use knitted background graft combined with a balloon expandable stent. The benefits of endovascular repair include decreased anesthesia and operative time, smaller operative blood losses, decreased morbidity and mortality, small bilateral growing incision, more rapid resumption of physical activity, shortened length of hospital stay, quicker recovery, higher patient satisfaction and reduction of the overall cost. Potential complications include aneurysm growth, aneurysm rupture, perigraft leakage, aortic dissection, bleeding, graft dislocation and embolism, renal artery occlusion due to graft migration, graft thrombosis, incision site hematoma, and incisional infection. The most commonly reported complication is perigraft leak, which is the seeping of blood from the new endograft back into the old aneurysm site. The perigraft leak may be due to an inadequate seal at either graft end, a tear through the graft fabric or leakage between overlapping graft segment, and may require co-embolization for hemostasis. Graft dysfunction may require conversion to the traditional surgical repair. With endovascular repair, there is a higher pre-intervention rate and need for long-term follow-up. Nursing management. Nursing management of aortic aneurysm and aortoiliac disease. Nursing assessment. A thorough history and physical assessment should be performed because atherosclerosis is a systemic disease process. The nurse should watch for signs of cardiac, pulmonary, cerebral, and lower extremity vascular problems. The patient should be monitored for indications of aneurysm's rupture such as diaphoresis, paleness, weakness, tachycardia, hypertension, abdominal by groin or periumbilical pain, changes in the level of consciousness. Establishing baseline data is important for comparison with the later postoperative assessment. In particular, the nurse should observe the patient closely for any baseline abnormalities. Especially, attention should be paid to the character and quality of the patient's peripheral pulse and neurological status. Pedal pulse side, that means dorsalis pedis and posterior tibial pulse side and any skin lesions on the lower extremity should be marked and documented before surgery. Planning. The overall goal for a patient undergoing aortic surgery include normal tissue perfusion, intact motor and sensory function, no complication related to surgical repair such as thrombosis or infection. Nursing implementation, health promotion, acute intervention, ambulatory home care. Health promotion. The nurse must be aware of the cardiovascular disease risk factors and be alert for opportunities to teach health promotion measures to the patient and their families. Special attention should be given to the patient with a family history of aneurysm or any evidence of other cardiovascular disease. The patient should be encouraged to reduce cardiovascular risk factors include BP control, smoking cessation, increasing physical activities and maintaining normal body weight and serum lipid level. These measures are also done to ensure continued graft patency following surgical repair. Acute intervention. The nursing role during the pre-operative period includes the patient and family teaching, providing support for the patient and family, and careful assessment of all body system. Pre-operative teaching should include a brief explanation of the disease process, the planned surgical procedures, pre-operative routine, what to expect immediately after surgery, and usually post-operative timelines. Although specific preoperative routines often vary by institution and or physician. In general, patient undergone aortic surgery typically undergoes some sort of bowel preparation. Example, that means laxatives, enemas we will provide in the preoperative period, and have a preoperative shower with an antimicrobial soaps the day before surgery, receiving nothing by mouth, that means NBO, after midnight the day before surgery, and often are given pre-operative intravenous antibiotics immediately before surgery. If the patient will be going to the ICU after surgery, or orientation to the ICU before the surgery may be helpful to the patient and family. Post-operatively, aortic surgery patient typically go to an ICU for close monitoring. When the patient arrive in the ICU, an endotracheal tube for mechanical ventilation, an arterial line, a central venous pressure or pulmonary artery catheter, peripheral intravenous lines, and indwelling urinary catheters and a nasogastric tube will likely be placed with a continuous ECG and a pulse oximetry monitoring. If the thorax is entered during surgery, chest tube also will be in place. Pain medication may be administered via epidural catheters or patient-controlled analgesia. In addition to the usual goal associated with the care of post-operative patient, example, maintaining adequate respiratory function, fluid and electrolyte balance, and pain control. The nurse must monitor graft patency and renal perfusion. The nurse also monitor for an intervenes to limit or treat dysrhythmias, infections, and neurologic complications. Graft patency. An adequate BP is important to maintain graft patency. Prolonged hypotension may result in graft thrombosis. Administration of IV fluids and blood components is essential for adequate blood flow to the graft. CVP readings or PA pressure and urinary output should be monitored hourly in the immediate post-operative period to help assess the patient's hydration and perfusion status. Severe hypertension may cause undue stress on the arterial anastomosis, resulting in leakage of blood or rupture of the suture line. Drug therapy will IV diuretics, example furosemide, or IV antihypertensive agents, example preside cardiopin may be indicated. Cardiovascular system. In individuals with the persisting coronary artery disease, myocardial ischemia or infarction may occur in the perioperative period due to decreased myocardial oxygen supply or increased myocardial oxygen demand. Cardiac arrhythmias also may occur due to electrolyte imbalance, hypoxemia, hypothermia, or myocardial ischemia. Nursing intervention include continuous ECG monitoring, frequent electrolyte and arterial blood gas determinations, administration of oxygen and IV antidyarrhythmias medications are needed. Replacement of electrolyte as indicated. Adequate pain control and resumption of pre-operative cardiac medications. Infection. The development of a prosthetic vascular graft infection is relatively rare but potentially life-threatening complication. Nursing intervention to prevent infection should include ensuring that the patient receive a broad spectrum antibiotics are prescribed. Body temperature is assessed regularly and elevation are promptly reported. Lab data are monitored for elevated WBC count, which may be the first indication of an infection. In addition, the nurse should ensure adequate nutrition and observe the surgery incision for any evidence of delayed healing or signs of any infection. Example: redness, swelling, drainage. All IV, arterial and CVP or peripheral artery catheter insertion sites should be carefully monitored and cared for using strict aseptic technique because they are frequent port of entry for bacteria. Meticulous perineal care for the patient with an indwelling urinary catheter is essential to minimize the risk of UTI. Surgical incision should be kept clean and dry. Gastrointestinal status. After abdominal aortic surgery, paralytic ileus may develop as a result of anesthesia and manipulation of the bowel during surgery. The intestine may become swollen and bruised, and peristalsis successed for variable intervals. A retroperitoneal surgery approach can be used to decrease the risk of bowel complications. An NG tube is inserted during surgery and connected to intestinal intermittent suctioning. This decompresses the stomach, prevent aspiration of stomach content, and decrease the pressure on suture line. The nasogastric tube should be irrigated with normal saline as needed, and the amount and characteristics of the drainage should be recorded. The nurse should auscultate for the return of the bowel sound. The passing of flatus is a key sign of returning bowel functioning and should be noted. Early amputation will assist with the reception of bowel functioning. It is unusual for paralytic ileus to persist beyond the fourth postoperative day. If the blood supply to the bowel is ruptured during surgery, temporary ischemia or infractions of intestinal tissue may result. Clinical manifestation of bowel ischemia include absent bowel sound, fever, abdominal distension, diarrhea, and a bloody stool. When bowel infraction does occur, reoperative is necessary as soon as possible to restore blood flow, with a likely recession of the infracted bowel. Fortunately, this serious complication is uncommon. While the patient is NPO, meticulous mouth care should be provided every few hours. If some situation, ice chips or lozenges may be given to soothe a dry or irritated throat. Ambulatory and home care. The patient and family may be apprehensive about returning home after major aortic surgery. The nurse should encourage the patient to express any concern and reassure the patient that normal activities of daily living can be resumed. The patient should be instructed to gradually increase activities, fatigue, poor appetite, and irregular bowel habits are also be expected. Heavy lifting is avoided for at least 4 to 6 weeks following the surgery. Any redness, swelling, increased pain, drainage from incision, or fever greater than 100 Fahrenheit should be reported to the healthcare provider. The patient should be thought to observe for change in color or warmth of the extremities. Patient can learn to palpable peripheral pulse to assess change in their quality. The patient who has received a synthetic graft should be instructed that prophylactic antibiotics may be required before further invasive procedures, include any dental surgery. Sexual dysfunction in male patient is not uncommon after aortic surgery. Sexual dysfunction may occur because the internal hypogastric artery is interrupted, leading to decreased arterial blood flow to the penis. In addition, the periaortic sympathetic plexus may be disrupted by the surgical procedure. Preoperatively, baseline sexual function should be documented and patient counseling is recommended. Postoperatively, a referral to a urologist may be considered if erectile dysfunction is a problem. There are situations in which operative repair is not performed. Examples of this are the presence of very small aneurysm. A patient who is not a surgical candidate, example, severe lung or cardiac diseases, or patient who refuse to undergo repair. The patient who does not undergo surgical repair should be urged to receive regular routine physical examination and should be reminded that any symptom, no matter how monitored, must be investigated if it is persist. Evaluation. Expected outcome for the patient who undergo aortic surgery include patent arterial graft with adequate distal perfusion, adequate urinary output, normal body temperature, no sign of infection.